So good morning. Welcome to this special session on cataract. On behalf of my co-chairperson, Dr. Arup Chakrabarti, I welcome all of you to this meeting. So we'll go to the first talk by Dr. Arup, which is on online IOL power calculation, here to stay. As we all know, Arup is a very senior cataract surgeon with so much of presentations all over the world. And he has done a lot of special interest, he has taken a lot of special interest in all the IOL power calculations, the formulas, which is the best, and he's an excellent teacher as well. Over to Dr. Arup.
Good morning, friends. Thank you, Sai, for the kind introduction, and thanks KSOS for giving me an opportunity to present my talk. So, we are all aware that today the refractive outcome of cataract surgery have become excellent. In a landmark study, Savini et al., using biometric data obtained from a swept source OCT-based optical biometer and newer formulas, the recent formulas, shown that prediction error of 0.5 diopter is seen from 88 to 90.67% of those patients. Provided, again, let me emphasize that you have got high quality biometric data and then you're using the newer formulas. This has come about, this excellence in our refractive outcome has come about because, as I just mentioned, we are very, very accurate and precise in our biometric workup. And then newer IOL power calculations, and that is going to be my focus today, particularly on the online versions of the IOL power calculators. And a brief history about the origin of, how the evolution of these power formulas have occurred. Generationally, we do use the generation classification of IOL formulas. This is a very chaotic, very random, and doesn't really make much sense in today's scenario. So a couple of years back, Warren Hill and his team, they reclassified the IOL power calculation formulas based on the method that is used to calculate the power and the data that is used to get these calculations. And then I think this is the latest classification of IOL power calculations. Don't worry, I'm not going through each and every formula mentioned here. But this is a very easy to understand formula classification. And there are so many formulas, and most of these are available online. So many of these formulas have to be, proved and re-verified in large volume practices. So today we basically stick to Barrett Universal 2 Heal RBF version 3 and the Olsen. Olsen formula is a paid formula. And then the new kids on the block, in fact, they have been around for quite some time, have been the Kane formula, EVO formula, the Panacea formula. And recently the Pearl DGS and Hoffer QST formula also have done extremely well. So my emphasis is on online power calculation today. It is because we all have the infrastructure. We have the computers, laptops, the internet, the wired or the Wi-Fi. So you don't require any additional investment for to use these calculators. Plus the availability, like for example, as soon as I get the biometric data in my desktop or in my smartphone, in cases of difficult challenging situations, when my office staff send it to me when I'm traveling or talking or when I'm not available in the office. So you can calculate it using, even your smartphone, what exactly is the IOL power that you want to be ordered immediately. And then multiple results. If you stick to one particular device, they won't have all the formulas. Many of these formulas will be outdated. They have not been, updated for a long period of time. So on the other hand, you have access to all these formulas. So you can definitely get an idea about what each formula calculation is telling you, to what is about the correct IOL power, whatever is your target refraction. So there are multiple results that are possible. And then, as I mentioned, there's power formula writers. They keep on updating the formulas very frequently, and these don't show up in the devices that you have purchased, and you definitely use most up-to-date formulas. For the spherical IOL calculator and other tools, there is a wide variety of formulas available. I am just going to tell you the ones which I use and from this list and which have given me good results. Even for the toric formulas and the SI calculators, we use the Barrett formula. It is a very comprehensive, exhaustive formula. And then EVO, this also has been doing well. Some of the formulas do not give results for cases where post-refractive surgery, LRI has been done, or post-hyperopic laser has been done for these patients. So you have to be very careful. So So most of these hallmarks are most of these new formulas, they have more number of variables, so which makes these formulas more accurate. Many of these newer variables that are required are actually optional. So if your measurement device doesn't measure it, that is also okay. You can still calculate the intraocular lens power. It may be more accurate if you had all the variables that were, that were incorporated in the various fields of the formula. And so basically try to get as many variables as possible. So my go-to format is always Variate Universal 2. It is free in the apscrs.org. It's a complete suite. It takes care of all your IOL power calculation requirements. And in difficult scenarios, in extreme cases, challenging cases, I of course see what the Kane formula tells, what the Hill RB formula tells, and then take a call. And if you have used an ultrasonic biometer to get your axial length, you can still use the Variate Universal 2 formula by adjusting your A constant. ACRS.org has got a lot of fields on, on the calculators and entire page on calculator and the tools. So here I really like the post-refractive IOL calculator, and Hill RBF calculator version 3 is again available here, then toric results analyzer. So rest of the formulas, some of the components of the Barrett calculator are also incorporated in the ACRS.org. This is the new kid on the block. It has been around for 5 or 6 years. Initially, people are not sure. Today, I think everyone is convinced, and I'm also convinced it does extremely well. It calculates for both non-toric and toric IOLs. It gives very good results for keratoconus patients. It takes the gender into account, say male or female, and so it has been doing extremely well. Another formula which it was published in AJO and it has been gradually gaining in popularity is the Pearl BGS calculator. So this also calculates the second eye enhancer. It has a feature called second eye enhancer. Like if operated on the first eye and given adequate period to heal, 8 weeks, and then you can use this formula. So you can get some idea as to what should be the target refraction for the second eye to be operated after ascertaining the refractive outcome on the first eye. I think this is a game changer. So among all the cataract organizations, AACRS, APACRS, they had their websites had IOL calculators. EACRS did not have one, but about 2 years back, they came up with this calculator. And once you calculate, so basically for spherical IOL calculation, there are 7 formulas that are taken into account. The beauty of this formula is once you input your biometric parameters, you fill in the fields. This particular site itself, approaches the 7 formulas, all these well-known formulas, and then calculates the IOL power. So, for example, if I'm going to use the IQ lens for a given patient, and my say 16.5 is the power suggestion for all these 7 formulas. So I can decide which power that I want to employ. If it is a toric lens, it is a Barrett, EVO, Hofford Q, AST, and Kane. These are the formulas this ESL's calculator uses. For extremes of eyes, I always take multiple formulas into account. Sometimes the older formulas have done better than the newer formulas in these cases. So friends, you must remember that in this game of IOL power calculation, you as the surgeon are in charge. Somebody else may be doing the calculations for you, but you have to be very, very thorough in your IOL power calculation techniques. You must be aware of what are the latest. Every peer-reviewed journal, every issue has 2 or 3 new articles which bring up a lot of new things. Proper patient workup, accurate biometric parameters have to be obtained. Use newer formulas, go online. And with properly optimized lens constants, trying to adapt to the new technologies as they present, anything new that is new may not be the best. But so you don't be really in a rush to change everything what you have been doing, and strive to use all available resources to their best advantage. Thank you very much for your kind attention.
Thank you, Dr. Arup. Next, I call upon Dr. Sai Kumar to give his talk on Catch the Runaway Rexes.
Arup, a very nice talk, because I always look upon you for all these IOL power calculations. What do you recommend, what formula you recommend for the hyperopic eyes? Because that is the most common challenge we face.
Actually, Mohan has raised a very pertinent question. See, hyperopic eye, like as I mentioned, in extremes of eyes, very long eyes, that's no longer much of a problem, but short eyes, hyperopic eyes, nanophthalmic eyes. So older concept was use the Hofford Q and all that. But today what I do is I use a Barrett Universal 2 I'll use Kane formula, and I'll heal RBF and find out, which gives us the best results. And sometimes I tell the patients that, the best formula also may not give you the most accurate result in the given patient. So we have to have a proper counseling system in place for these patients. But these are the 3 formulas that I would definitely look into for very hyperopic eyes.
Thank you, Dr. Bastin and KSOS for having me in this session. And I'll be speaking about a few case scenarios where I had problems with the rexis. This is just a video-based presentation, no written slides in this presentation. So let us start with a slightly old video of mine, which is this is about nearly 10 years old. This was a young patient with a very intumescent, cataract, but inside the lens there was no material. The moment I touched the capsule, the whole thing, split. The capsule split open with a typical Argentina flag sign. In these cases, with a very soft lens material, you can safely go ahead with a phaco. Now, whenever we see this, there is always a feeling that probably we should not do phaco, maybe we should convert to SICS. But when you have a split like this, which is uniform in both sides, it is not a very hard cataract, you can safely go ahead and do phaco in these situations. So here what I am doing is a 3-piece lens. I am putting it into the bag actually, whatever bag is there, the 2 sides. And then once it is gone into the bag, I cut the 2 sides of the capsule and make it into what I call the hemirexis on both sides. And so this 3-piece lens is well centered inside the bag with an intact PC. Now when you have a single runoff, the runoff can happen at various points. Okay. So this was again a slightly intumescent cataract. Mind you, when you don't have fluid leakage from inside, those are the dangerous ones. You have those, thick fibers there. So here I was not able to approach through the side port. I went through the main wound. I couldn't do it there. And by the time I tried to get another instrument to, salvage, this had just cut off. So I decided because it was away from the main port. So which means my cracking maneuvers are away from the main port, and so I decided to go ahead with phaco in this situation. So if you have something that is away from your main port, it is slightly safer to go ahead with phaco. There is nothing that is absolutely safe, but if you have something that's away from your main wound, probably you are slightly more safer in going ahead with a phaco emulsification. So then you have this situation where the rexis is sub-incisional. So the moment you touch the capsule, the whole thing comes towards your incision. These are the ones that I usually tend to go in for an SICS. Because when you go in and crack these nuclei, your crack force is along the area of your rexis runoff. There is a high chance that it can go into the posterior capsule and become a wraparound tear. And so in these situations, I usually prefer to convert into an SICS, whereby actually this is not a very hard cataract. This was intumescent but a slightly soft cataract, and so it was coming out piecemeal through the SICS wound, and then again the lens goes into the bag because it was a single rexis extension. These are capsules that you come across once in a while. These are fibrosed capsules. So when you have capsule fibrosis, obviously you have to stain the capsule, but then you try to go around the area of fibrosis. So that is the key here. Sometimes you may not get, but here I was able to get a small area beyond the area of fibrosis, and I was able to complete this rexis. And in a rexis like this, once you've got a complete rexis, then you are very, very safe because the remaining part is fibrosed. Even if you have a small tag somewhere, you can actually cut it with the scissors. And these are actually safe capsules which usually do not, run off into the periphery. This was another young patient with a fibrosed capsule, but when you have extensive areas of fibrosis, one of the problems is that you don't get to stain the capsule properly. So in spite of putting so much of stain on the capsule, the fibrosed areas have not taken up stain, and so I'm finding it very difficult to visualize the capsule here. So I make this capsule till it is halfway, then I'm not able to see again. I'm trying here with a microrexis forceps. Here I have lost the visibility of the capsule yet again, and so what I have done is I have just gone ahead through whatever capsular opening is there I finished the phaco, but then I found out that there was a fibrosed area here with a small tag here. So I am cutting the capsule there, extending the tag, making it into a rhexis, and then going ahead with an intraocular lens. So the message here is that in a fibrosed capsule, if usually it does not run off much to the periphery if you are very, very careful with that. Now, how do we retrieve a runaway rhexis? Now, this is a case where this is the technique that I usually do. I make a small rhexis and then with a Simcoe or a bimanual, I wash the cortex. But here, as I was washing, this rhexis has ripped here, but luckily it has not gone till the periphery. So I can still see the edge here. So I have put viscoat in the anterior chamber. You should not overfill at this point. Be very careful. If you overfill, the overfill itself will make the capsule to rip. But here, the right fill of viscoelastic there, flattening the surface of the anterior capsule, helps me go the other way. Normally, I do the rhexis in this direction, but in some situations, you will have to do the rhexis in the opposite way. If you are not doing it daily, you have to do it a bit slowly. Probably even use your left hand to do the rhexis if you are a right-handed surgeon. And then the rhexis got completed here, and phacoemulsification was done just like in any other case. You can have rhexis fibrosis which is hidden. So this is a small pupil about grade 3 to 4 cataract. I decided to go in with iris hooks in this case, and once I started the rhexis, I found out that there was an area of fibrosis here. So I then crossed the area of the fibrosis and went ahead with the rhexis completion. I went ahead with phaco, and towards the end of phaco, I realized that this area there is a large PC rent. So wherever there is an area of fibrosis, visibility in these situations is extremely important. You have to be sure you have done a proper rhexis. That makes a big. Here, luckily, I did not have a drop. But if this was a very large, rent which had occurred earlier in my surgery, probably I would have dropped the nucleus. So I went ahead and did an anterior vitrectomy there, and there was enough rim for me to implant a 3-piece lens in the sulcus. Although with a rhexis which is not intact, we cannot capture this lens, but the 3-piece lens goes into the capsular sulcus. Now coming to a Morgagnonian cataract, these capsules behave slightly differently. They don't usually run off to the periphery. The Morgagnonian ones with milky fluid inside normally do not run off to the periphery, unlike the intumescent ones. So in these situations with very hard cataracts in between, my personal choice of preference is an SICS. So here I have just made a nick here, the milky fluid is leaking out. I'm trying out with the microrhexis forceps, is again leaking out. So I made a tunnel, I washed the fluid there, and then I used viscoat. No financial interest, but in these situations, viscoat is a very, very good tool to maintain the chamber. You can see that I go through the main wound with the utrata forceps, and then, complete the rhexis. The chamber does not collapse at all. So, in these sort of situations, usage of viscoat is extremely important. And with this very hard cataracts with just milky fluid and inside, as I mentioned before, I usually prefer to do an SICS. I've tried doing phaco with a lot of flower patterns and things like that, but generally corneas are a bit hazy the next day, so I generally go in with an SICS. So what is the ideal way to do? I generally do what is called a triple rhexis. So you have done your first rhexis, and then you enlarge and make it into a second rhexis, and then you can go ahead with your phacoemulsification. And once you finish that, you can go ahead with a third rhexis. If you think that your rhexis is overlapping the IOL for more than 1 millimeter or 1.5 millimeters, then you can go ahead and do a triple rhexis and have a nice coverage in these cases, and also prevent capsular phimosis. Is femto the answer for all these intumescent hyper mature cataracts? Not probably in all cases. This was a femto rhexis that was done. Usually in femto rhexis, it's always better to stain in these white sort of cataracts, because if you don't stain it, you may not see small tags. So here I found that there was a small area of tag here in spite of the femto. So you have to stain the capsule very carefully, fill the chamber with viscoat, and use a utrata forceps to make this capsule into the round rhexis that we normally need. So in summary, understand the capsule physics well, understand that capsules are different in white intumescent cataracts, in hypermature cataracts, in Morgagnonian cataracts. The capsules behave differently in these sort of situations. Staining and visibility are extremely important. chamber maintenance is very important. Use an ideal OVD. Don't, try to reduce your cost by using HPMC in these situations. You do need better OVDs in some situations. You need proper instrumentations like your micro-axis forceps, your micro-axis scissors, your utrata forceps. Always have an alternate surgical plan. So in case it doesn't work out the way you want, are you going to change the lens? Are you going to change into an SICS from phaco? So alternate surgical plans should always be in your mind. Thank you for your kind attention.
Thanks a lot, Sai. So the next lovely video, Sai. Next speaker is our own Dr. Minu Mathan. Tips to master using BHEX ring. The time allotted is 8 minutes, so I would request all the speakers to stick to the time limits.
Good morning, ladies and gentlemen. Thanks, Dr. Bastin, for having me in this session. So I am talking on, one of my batchmates always used to tell, even we small pupil hooks on the Paranjonde, so I thought decided we'll just stop talking about hooks and then start on with rexes, the rings. So no financial interest in this, but I'll be talking on a particular type. So look at this pupil. So this pupil looks very small, is it not? So if you look at this carefully on the top part, although it's not very clear, it's written 4.9, and this pink ring is 4.9 millimeters. So it is basically at least 5.5 millimeter pupil. So it is not, everything is not as small as we think, although it looks small. But then when it looks small like this, if you are not able to do a good rexis along this size of pupil, I would always put in a dilating device. So my now go-to thing is this BHEX ring. So there are specific forceps. This is a regular forceps which I am using. It can also be used, but ergonomically the others will be good. So I hold on to one of those loops there and then tilt a little with having a little visco underneath the iris also, and then tuck it in. Then go from the paracentesis. That will be good to have the chamber form very well. Hold on to the center. You can either hold on to the side circles also and engage one by one. But I feel now holding on to the center and tilting it sideways will be an easy way to get the whole thing in one shot. So two flanges are gone in. Now the last one is more difficult. So towards that I put little more sodium hyaluronate inside and then fill up and then use two instruments. One is the forceps through the side port and second is a Kugel-Suk. So I push this one flange a little forwards and then pull the iris a little backwards. So here by doing it on both the sides, you can stretch half only. Otherwise, if you stretch the iris, you will have to stretch double. So now see, this is a pseudo-exfoliation case. The pupil is dilated to 5.5 millimeters. So this is more than enough for us to do a 5.25 or even a 5.5 rexis. If you have done a rexis and if you are sure that the pupil is not going to come down, that is more than enough for you to do a clean phaco. So here you can notice that this is a very thin profile thing, and because this is a pseudo-exfoliation case, it has maintained the pupil size all along the surgery. It doesn't come down. You don't have to worry about the iris at all. Otherwise, we have to keep worrying about not going close to the iris, no irrigation hitting the iris, pupil coming down. All those things can be just forgotten. And the thin profile does not get it into the way of your instruments at all. And one more good thing is that you can move the ring like a photo frame. If you want to see one particular point, just push it with your second instrument. And the IOL goes into the bag, and make sure that leading end goes straight into the bag. Don't land it in the anterior chamber. And before the haptic opens, the trailing haptic opens, it is better to get the haptic optic junction into the bag. Don't slide the IOL over the ring. That is one way you can avoid the dislodging the ring. Now I am just showing how to dislodge all the three flanges. You need not actually. I'll show you in further cases. It need not be completely dislodged. Only one is enough. And once it is in the anterior chamber, you can just hold it and withdraw. So this is supposed to be a disposable product. So now see the pupil. It has not been distorted much at all. You know, if it is a very small one, sphincter tears may happen, it will be there. But then see, it is relatively very, looks untouched. So that is one good thing about these rings. So look at the centration. So this is the Varion coming on, and if you have placed it properly, see the centration. So you will get a very centered pupil, and your rexus is going to be very well centered, and this ring is a good marker. If you don't have these kind of markers, this is a very, you will get a very well centered rexus for the later implantation of, especially look in this case here, there is a toric IOL which is going in. So the toric IOL marks are clearly seen at the edges. One at least you will be able to see in this pupil size. That is enough. Because in a small pupil, retracting it and seeing and then trying to adjust the IOL is very, very difficult. So after I wash all the visco and underneath the IOL also, and then position the IOL, then I put in again sodium hyaluronate into the anterior chamber alone for the release of these hooks, the ring, and taking it out. Because I am not very comfortable doing it under saline, although it is possible. Under irrigation, it's possible, but I am not very comfortable. Sometimes iris, pupil iris comes out through the incision and all those. And here, see, look at this pupil. If it is a 5.5, 6 millimeter pupil, we may think that IFIS may not happen. See, intraoperative floppiness when the patient is on tamsulosin. But at any stage, this can happen. See now what has happened? I just turned my tip towards the side, the irrigation went underneath or along the iris, and suddenly the billowing starts and the flutter happens and the pupil comes down and I accidentally catch the iris. So remember, any patient on tamsulosin and having a soggy looking iris like this and a mid-dilated pupil, there is always a tendency for this pupil to come down. So your incisions have to be appropriate for the size of your instruments which you use, well-fitting ones, not loose. See, when I irrigate, see the flutter of the iris. This is one indicator that the iris is going to be floppy and it is going to come down on you. So I went ahead and did a rhexis of 5 millimeters, 4.85 millimeters, but then still, this is at the beginning itself, when I am starting phaco itself, see the way the iris behaves, and it has started coming down. So to avoid this kind of a situation, putting in a ring or a hook at this situation is possible, but it is more risky holding the rhexis margin and all those while placing it. So if you find one like this, I'll straight away place a ring in the beginning itself. So this is the forceps, B-hex forceps which is applied along with the ring. The ergonomics, the bend and all those, it's much better rather the regular forceps which we use. And here also it opens up down the jaws, not the sideways opening like the other one. The same thing which I showed before, but have all these air bubbles taken out. Because exactly where you want to do something, that air bubble will come and sit. So always take air bubbles out and then use this two-hand maneuver for the last one, sub-incisional. Retract the iris and pull the ring away so that you can engage it very well. So here again, not to drag the IOL along, not to hit the so here I am taking it out through a paracentesis. So this even comes out through a paracentesis of 1 millimeter opening, that is also possible. So even then coming on to pseudoexfoliation ones with rigid pupils, if it is a rigid pupil, it is always better to give it a little stretch, because this is a very thin profile one, not very sturdy as the Malugian ring. So it is always better to have stretch on the sphincter so that we can easily engage the ring. So here is the UBIT case. It has a posterior synechia and this fibrin. You can see the fibrosis at the pupillary margin. And we release the posterior synechia and give it a stretch as we saw before. And here, this is in 2018. This was the early stages of development of this lens. And I was one of the evaluators of this, not lens, ring. This is the earlier version we were trying to use with the Sinsky and all. But now we have all changed to the forceps alone. And here, if you notice, see the bending. See the bending of the ring. This was because I had used it multiple times after autoclaving. So I don't suggest use autoclaving, but you can even ETO or use a plasma sterilizer and then it may retain for, see the bend which happens. So even with this bending, it can hold on to the iris, and if you then shift a little bit, as I will show you, this looks a little small now, but if you just push along the flanges, it will actually create a 5.5 millimeter opening with which you can continue. So I would suggest, I have now gone away from using iris hooks in routine cases, especially in sonlar dialysis or in a PC rent. If I need to have a very large opening, then I use iris hooks, or in a very intumescent lens, if I have a tendency for a runaway rhexis or an extension, I want to see the periphery of the bag, then I use hooks. Otherwise, I don't use hooks at all now. Thank you very much.
Thank you, Minu, for that wonderful presentation. I request Dr. Mohan Rajan to speak on IOL scaffold, and by the time he gets ready, one or two comments, Minu. One is putting viscoelastic under the iris before you tuck in the B hex is very, very useful. And if you don't have that special forceps, you can still use a good Sinski hook also. So you have the flanges where the holes are there, and you can tuck the whole flanges under the iris and the straight flanges above the iris, so that you get a nice opening.
In some of these Sinskis which come now, I have very sharp tips. So be careful about using Sinski. Some of them are very sharp. It can damage your anterior capsule.
Thank you, Binu. Mohan Rajan, sir.
Thank you very much, Sai and KSOS for the wonderful opportunity. It's always a pleasure coming back to Kerala. I'm going to show you 7 different scenarios. This is a Morgagnian cataract, the small pupil as well. You can see this Morgagnian cataract. What is the biggest problem? The biggest problem Morgagnian cataract, because there is no posterior support to this nucleus, and very difficult to do a rexis. So what I do is I put iris hooks. In these conditions, iris hooks definitely has got a better this thing than your BX or a Mulligan. So I put iris hooks and make then stain the capsule, of course, being a hypermature cataract as well, and then I make a rexis. Okay, I managed to do. See, the problem in the Morgagnian cataract is do a rexis because there is no peripheral resistance. There is a universal zonulopathy. All around the zonules are also weak. The bag is very lax as well. So I was able to do a rexis there, and then further I go ahead and normally this nucleus is a little small in Morgagnian cataracts, and it moves around in the bag, and that's the reason why it's always difficult to do a phaco in this case. So what I thought was, once I do the rexis, I'll go ahead and put a IOL scaffold, bring this nucleus up. And I put once I do that, I put an IOL scaffold there. Sorry. Yeah. So I bring this nucleus up and then put an IOL into the bag. Okay. The mistake I do here, I just want to show you everybody, because everybody should learn from our mistakes. So the mistake I do here is, see, I expand the bag nicely with sodium hyaluronate and then put a lens into the bag. Okay. So I thought this IOL will fill up the bag and then go ahead with the phaco of the nucleus piece. But the problem is I didn't put the trailing haptic into the bag. So I thought that's a mistake I did. So the trailing haptic is not in the bag. Because there is a zonular dialysis, you can see here I tried to phaco that this thing, which I shouldn't have done without putting the lens completely into the bag. Through the zonules, the vitreous starts coming out. Now I am in trouble because the vitreous start coming out, and there is also, and then I put viscoat into the anterior chamber. Then I do an anterior vitrectomy, and all these things happen. So you can see here I am doing anterior vitrectomy because the PCR has occurred. And now I am in double trouble because I have the IOL, single piece IOL, as well as I have the lens nucleus. So I need to, so I keep the IOL as a scaffold there, and then use the vectis and remove the nucleus, and then remove the IOL and put a lens, because the capsular rexis is still intact. I put a lens in the bag and the patient did very well. But this is just to show you another case of Morgagnian cataract. I learned from my previous mistake. Okay, you can see here, as I think Sai was rightly telling, the problem with this rexis is that because your visualization is so poor, and then you do this and then go ahead with the rexising. And because I told you again, this is a problem with this with the rexis. You can see here I'm doing this, and then in this case I do this. See, it's so difficult to do the phacoemulsification because the bag is so wobbly there and bag is so lax. So I bring this nucleus after removing quarter of the nucleus, the remaining 3/4 I put it there. You can see how small my rexis is, it doesn't matter. In this case what I did was I put the lens nicely into the bag. You can see a single piece lens nicely into the bag. Though it's a small rexis, always make sure that when you put the lens in the small rexis, always make sure that you release the trailing haptic as late as possible, and then put viscoat, lot of viscoat into the anterior chamber and phaco this
not close to the corneal endothelium, but slightly in the posterior plane, or what we call the iris plane. And then subsequently I extended this rhexis because the rhexis is a little small, and this patient had 6/9 vision. You can see this again a patient who had a wrong IOL. Okay, instead of 18 diopter, we put 28 diopter, and you can see here I had to do an IOL exchange after about a week after the post-op, after the surgery. Then what I do is in all the IOL exchange, I bring this lens up. Okay, I don't cut this lens immediately. I bring this lens up into the anterior chamber. Of course, viscoelastic is a game changer in my opinion. Then I put a lens into the bag and then cut this lens. Okay, now I'm very safe, because if I cut the lens in the presence of an open posterior capsule, then the possibility of a damage to the posterior capsule, entire bag, entire this thing is lost. See again, you can see here, this is a patient. I'm using a very high-end machine. It's a grade 2 walk in the park case. You can see here, as I'm taking the last piece out, what is happening? There's a sudden surge, something like a posterior capsulorhexis. Immediately I bring this nucleus up in front of the iris and inject viscoat into and to plug the tear and put a lens. In this case, I had to put VVT because the other eye also had VVT, and I put a VVT lens, and again I put the lens into the bag, and the trailing haptic is not in the bag, of course, which I found later. And then I did the because the IOL acts as a good scaffold, and then I found out that the lens is not in the bag, and put it in the bag and then put a bimanual IA. Once you have a problem, you always shift to the bimanual if you are already on coaxial. Then I found the vitreous is also there. I didn't use tricot in this case. The patient had a steroid response in the other eye, so I didn't want to have a tricot. You can see here the postoperative picture is very good. So again, you can see here another patient with the PCR and IOL scaffold. You can see here this is a fairly not a very large pupil as well, and I'm going ahead and I find out that there's a small not a small, fairly large PC tear. So I bring up this nucleus in front of the iris, and then making sure that you remove the vitreous first and then remove the cortex and then remove the nucleus. Don't remove the nucleus in the presence of these things. Always making sure that the vitreous and the cortex are there right in front, and then making sure that now and then you put viscoat. The viscoat I think is a very important thing. I don't have any financial interest. Alcon is not paying me a single paisa, but I'm just telling you the viscoat goes and plugs it. Then you do a bimanual anti-vitrectomy. You can do it to the pars plana as well. You can use tricot now and then to find out, delineate. Always remove the vitreous first and remove the cortex, and then subsequently I did the thing and put a 3-piece lens into the sulcus and removed the remaining nucleus into the by means of phacoemulsification, acting the IOL acting as scaffold. This is a patient I had to do a vitrectomy, IOFB removal, the expanded indications for his IOL scaffold. I brought this iron piece up into the anterior chamber. If I open the incision and try to extend it, the iron piece would have gone back inside. So what I did was, since the capsulorhexis is quite intact in this case, I put a 3-piece lens there, which acts as a scaffold for me to remove the IOL, the IOFB, the intraocular foreign body, which comes out without any problem, problem of the IOFB sinking into the thing. So I would like to thank KSOS and wonderful opportunity in the patient attention as well. It's always a pleasure being here. Please email to me to drmohanrajan@gmail.com. I'll send you a color atlas or retina and optic nerve. I seek your blessings and support for my AOS elections this year. Thank you very much.
Thanks a lot, Dr. Mohan Rajan. See, any surgeon will have complications, but what he has brought out is how well those complications have been managed without affecting the eventual outcomes for the patient. And we will now move on to the last talk for the day by Professor Vinita Gupta. She is from AIMS Rishikesh. She also does a lot of work on glaucoma and a lot of other miscellaneous activities in ophthalmology. I hope you are participating in the cultural program in the KSOS. Choosing an IL for a child, it's not a child play.
I thank KSOS and Dr. Bastian for inviting me here. So my talk will be on choosing an aisle for a child. It's not as easy as a child's play. We know there are lots of developments and advancements in technology has already been shown by the improvement in the aisle formulas for the adult eyes, but the field of pediatric cataract surgery is still lagging behind regarding that. And why do we say the aisle power calculation in a child is different? Because we're trying to choose an optimal aisle power for an eye that best befits a small eye. It's an eye which is not actually a miniature eye, but it's an eye which is a growing eye. So we are implanting a fixed aisle power in an eye which is still growing. The younger the child, the more difficult is the problem. And we are using formulas which have been designed for adult eyes. We do not have any formulas designed specifically for those growing eyes. And then we have the measurement issues, which are the various concerns of measuring the mean keratometry in the axillary length, the main parameters for your biometry, the various materials and the choice of the aisle, what should be the aisle best, which is suited for these children. The calculation formulas I've already talked about, and what is the target refraction which we are aiming at. That's another big issue. And then the long-term issues of the myopic shift, which is happening in these children as they are growing, and the visual axis of opacification. So if you see by this graph out here, you can see the normal eye growth is occurring at birth. The axillary length is around 17 millimeters, and there's a rapid growth in the axillary occurring during the first 3 months. Similarly, at birth, the mean keratometry is around 51 diopters, and the rapid increase and stabilization to the adult values occurs by the first 18 months of life. Similar is for the lens power. For the first year, it is a dramatic decrease of almost 10 diopters in the power of the lens, or the natural crystalline lens. So if you look at this figure, and as I shown in the previous graph, the maximum myopic shifting is occurring during the first 2 to 3 years of life. Besides this normal eye growth, the other factors which affect your myopic shift in a child is the laterality of the cataract, whether it is a unilateral or bilateral cataract. What is the time when we are operating this child, whether we are leaving a child aphakic or we are implanting an IOL, and obviously the genetics of the child, depending on whether his parents are myopic or not. So remember, as I said earlier, this is not in a miniature eye. The pediatric eyes are not miniature eyes. They have a different anatomy altogether. They have a shorter axillary length, but at the same time, they have a steeper cornea with very high keratometry readings and a smaller anterior chamber depth. So the standard aisle power formulas which are using for the adult eyes are inadequate for them, because most of these measurements are being done by the ultrasonic biometers. So obviously, the velocity of the ultrasound through the different structures will vary in these. Then the measurement issues, as I said earlier, we have most of the children, especially less than 2 years, 3 years, it's very difficult in the office settings. Most of the time, we have to take them to the general anesthesia and do measurements there. And this also leads to errors in measurements because we are not coaxial exactly when you are doing measurements under GA. Then second issue is the lower ocular rigidity. So obviously when we are doing maybe doing an immersion biometry, applanation tonometry is one what we are doing. Applanation contact ultrasound is what we are resorting to most of the times, because they may not allow, especially when we are doing it not without anesthesia. So they will be compressing on the eye when we are doing an applanation or a contact ultrasound. And those cases, obviously, there is low ocular rigidity in these cases, and hence there is more impact of compression. For an adult eye, if it is about 2.5 diopters per millimeter of compression, it is about 3.75 diopters for a child's eye because of lower ocular rigidity. And if you're going under anesthesia and we're trying to measure these using a handheld keratometers for the keratometry readings, obviously we are not coaxial. So obviously this leads to inaccurate keratometry readings, and also the cylindrical values, especially if there's a high astigmatism, they're not very accurate for your using the handheld autokeratometers. Also, every center may not have a handheld keratometers. Infants, also remember, this has been seen in certain studies that girls tend to have, girls tend to have a steeper corneas. And also in the bilateral cataracts, the keratometries are steeper as compared to the unilateral cataracts. Then we have the issues related to measurements of the axillary length. Obviously, as I've already discussed, immersion would be the preferred technique, but again, when we are doing it not in the awake position, in an awake child, or whether in anesthesias, we are not exactly perpendicular, because it's very difficult to instruct a child to look directly into your light of the ultrasound probe. So best is to measure in the calf, use the calf method, which is to measure in the aphakic mode and add 0.32 millimeter to that, because this is averaging out the velocity of the ultrasound when we are doing and taking care of the rest of the structures which have different dimensions. Optical biometry obviously would be preferred, but it can be done only in older children. And the effect of cycloplegia also is important, and it's important that even for the adult eye we say that, but for children it's much more important that do not dilate before you do these measurements. And then with IOL power calculation issues, since these IOLs which are required for these children are much, much higher powers, hence more exact axial positioning is required for these. Because of the various issues which I mentioned earlier, shallower ACDs, greater vitreous pressure, steeper corneas, and obviously the capsular contraction syndrome, which is quite common in these eyes, the results of the axial positioning or the exact positioning of IOLs is much less predictable in these cases. Any of these formulas do not work for pediatric IOL corrections, and more is the variability, lesser is the age. The desired, obviously, as a pediatric ophthalmologist, my desired aim is to hit the target. Generally, we undercorrect. Higher the IOL power, greater would be the undercorrection. For bilateral cataracts, I would go for greater hyperopia. For unilaterals, because of the risk of amblyopia, I do not want much of an anisometropia. So I will aim for a lesser hyperopia. If there's a dense amblyopia, again, I will aim for a lesser hyperopia. If there's a poor compliance, again, I'll aim for a lesser hyperopia. And if the other eye is a unilateral cataract, the other eye has a significant refractive error, I will aim it closer to the refractive error of the other eye. So this is the general dictum which I use in my practice. For unilateral cataracts, I usually aim for the spherical equivalent for children less than 4 years, minus around 1.25 diopters. But if it is more than 4 years of child, I usually make it equal to the spherical equivalent of fellow eye. For infants, the infant aphakia treatment study obviously was asking the infant to be left aphakic, but nowadays the trend is towards implanting an IOL, even at the age of 3 months of age. So for less than 6 months, usually leave a moderate hyperopia of around 3 to 7 diopters. For more than that, it is usually around 3 diopters, 1 to 3 diopters, depending upon the other eye status, or whether it is a bilateral cataract, around 3 diopters. Then we have a pediatric IOL calculator also available to predict the growth, the future growth of the child, which is available on the SKRS site. These are the general undercorrection guidelines I follow in my practice now. For less than 2 years, obviously, there's more spurt of growth. So obviously, earlier Dahan said all 20% for all children less than 2 years, but now we vary it for the age, according to the age of the child. And for more than 2 years, it is reduced 1% per year of age. And the best choice for the primary IOL placement and doing an optic capture, which could be in the bag or behind the posterior axis, or doing a primary piggybacking, which is you place one IOL in the posterior chamber and one in the sulcus, and remove or change the power of the sulcus IOL at the times as a child's eye grow. Best would be an hydrophobic IOL in the in the bag. Multifocal IOLs and the toric IOLs obviously can be our preferred modality if unilateral cataracts, if there is a significant post-traumatic cataract with significant corneal perforation which is repaired. And for secondary IOLs, again, remember, you are usually not able to place in the bag. Usually they are placed in the sulcus or the NDA chamber because the capsule has contracted and you're not able to usually separate them when you're operating at a later age. Hence, when you're doing the measurements of the secondary IOL calculation, again, we have IOL calculators for that. But remember, these patients may have been on RGPs. So please take your measurements after removing the RBGs, such as the last slide. And whatever is the type of IOL which you will be using for these could be a scleral fixated, the iris fixated, the retro iris fixation lenses are also available nowadays. And for secondary the scleral fixations, I have started using it in children after the age of 5 years. It works well, especially using the Yamanese technique. And piggybacking can be done for the secondary IOLs as well. And so to summarize, I will just say, customize for each eye according to the age, the laterality, the visual potential, the visual amblyopia status, the likely compliance with the contact lenses if you're not, if you're leaving the child aphakic in the primary setting, family history of myopia, and whether you're placing the IOL in the bag or in the sulcus or in the NDA chamber. So in the end, just to summarize, I would say careful consideration to the growing parameters of this child is very important to make the child as emotropic as possible when they are growing, when they actually reach their adulthood. Thank you.
Thanks a lot, Dr. Vinita. It was really a very wonderful presentation. We have Dr. Ramamurthy not present here today, so we have about 10 minutes of discussion time. And so anybody from the audience would like to ask or add on to, ask any questions or add on to what have already been presented, any queries or any clarifications? Rajiv?
Sir, I just had a question. For your talk.
This is to Dr. Minimathan. When you have a very floppy iris, the dilatation was about 8-9 millimeters, fully dilated, but midway it becomes very small. What is the technique you advise? What type of ring or a hook to expand it? Because your rexus is there behind. When you try to put, what is your advice about that?
So if it is a IFS case and a patient is on tamsulosin, it's a different issue. But there are some cases which will dilate very well, and because of your manipulation, it just comes down. So very little dilating drops, and it just comes down. So such cases, if you use intracameral dilating drops, it will dilate.
Yeah, but
So
still
that
it's
is
not,
one situation. But the other situation is patient is on tamsulosin. So the intraoperative meiosis is the only thing which we can control with your rings and hooks. But the floppiness and iris prolapse and all will keep happening. So we have to deal with that in the regular way which we deal. But iris hooks will be more easy to place in when the pupil comes down after a rexus, or when you have done some bit of phaco and the rexus margin is not very clearly seen. So iris hooks, once you put, before putting iris hooks, we will put sodium hyaluronate under the iris and elevate the iris. And then put one hook one by one, catch and lift up and pull. And then once you cross the rexus margin, see whether the bag is also moving while pulling. And then one hook is on, and then it is an elevated, there is a tenting up. And along the tent, you can put the next hook, and then the next hook and the other hook. But if it has become very small, putting a ring is also fine. Because if it is very close to the rexus margin, then you have a tendency to hook onto the rexus margin also. If it has come down below 4 millimeters, you have done a larger 5.5 rexus, then putting in a ring is also not very difficult, except that you have a tendency to hold on to the rexus margin if it is close to the rexus margin, 4.5, 4 millimeters kind of stuff. So again, elevating it with viscoat or sodium hyaluronate under the iris will prevent to some extent holding on to the rexus margin.
Yeah, I would do exactly the same, but I would prefer only iris hooks in this such a situation. The reason why, because malignant ring or BX ring, there's a possibility of the rexus getting caught. In iris hooks, what is the advantage is, once you put sodium hyaluronate, elevate the iris. Putting the first hook is a little difficult. Once you retract the iris, then subsequently you know exactly where your plane is. And put the microscope also on retroillumination to find out where exactly your rexus margin is. And all these IFS cases, I always stain with trypan blue, even if it's an immature cataract, because you know exactly where your rexus margin, and because the pupil comes down, you know exactly where your rexus margin is, so that you can put the iris hooks accordingly.
Thank you.
I have a question for Sir you only. I have a question for Dr. Arup only. Sir, what is your take on doing optimization for your own cases using any of the calculators which are available? Holiday's oil constant is there, or like there's a dynamic oil optimizer which is also available. So,
See, there was a time, it was the in thing to optimize your A constants, about 10 years back or so. So today, I think I don't do it. The reason for that being, take all the modern calculators, Hill RBF, or you take Barrett or any Ken formula. They would have used all the IOLs with international footprint, huge quantities of lenses that have been used, and they have already optimized the A constant. So for me to use, such large numbers of IOLs of that particular category, for me to generate a reliable A constant, it'll be quite an effort. In fact, it can be done if you can send your data to Warren Hill, he'll calculate it for you. Now, there are a lot of A constant optimization formulas available. I no longer do it. And most of the time, I have found that this practice has been quite good enough. See, every formula will have a particular IOL, what is the A constant, or the SF factor, or the ACD factor. So I think one is quite safe using those. But I agree, till about 10 years back, we used to do the A constant optimization. But you need to do, say, for example, if you're using the high gaze lens, there are three constants. You have to optimize all the three constants. Yeah, every patient. So it is not very easy task. So today I think if you're using a standard lens, which have been used by most of us, not a new lens in the market, you can use A constant, which is already there in the website.
Another question for that ECRS, which we issued for the normal spherical IOLs. You showed there were 7 or 8 formulas. So do you average out the readings of that 7, 8 formulas when you're taking for your own patient, or?
So I think I perhaps do not emphasize that aspect. The question is ECRS calculator. So there are 7 formulas, the newer formulas which are used with the calculator. So here is the advantage. you just feed in your data once to the ASLS calculator, and the ASLS calculator itself, will approach, fill in the 7 formulas. Everything is happening online, and get the data back for you. So you don't have to take, earlier on, before this calculator came, every online formula that I get, I take a printout and compare the printouts, or we have minimize and watch and minimize and watch. So it was very cumbersome. So today, let's say I'm using an IQ lens. I put in that IQ lens. For the IQ lens, let's say target refraction is 0 or minus 0.5. I put it as that. And then in one printout or one single screen, you have all the 7 formulas telling you what exactly is the residual refractive error if that particular lens is used compared to whatever your target refraction was. So it has made it very, very easy to handle.
So what do you choose then? Yeah.
I use my target. No, so most of the formulas will tell the same thing.
Yes. Okay.
So most of the formulas will tell the same thing, but so life has become easier.
Unless otherwise it's extreme axle length.
Earlier he used to have go to the heel RBF site, then APS-CRS site, Kane site. So it was more time consuming. So now everything is coming.
One single sheet. Yes.
And one final question: when do you use the Kane formula?
I use
a go-to formula in which
for the toric calculators, I use the extreme formulas, extremes of axial length, hyperopic eyes, myopic eyes.
Hyperopic eyes.
Yeah.
And
myopic eyes sort of have been sorted
keratoconus.
out. Yeah, myopic eyes sort of have been sorted out.
Yeah.
But when keratoconus, as you know, hypermetropic eyes with keratoconus, that has been known to give good results. This formula.
So it's 11:25. We'll wind up the session. I request Dr. Arup to give a small memento to Dr. Vinita Gupta, our invited faculty.